In the first 6 hours, you have to see ECG. ECG is the gold standard. Cardiac troponin 1, it rises after 4 hours, then 1 day, then depletes in 10 days. 4 hours, 1 day, and 10 day. Rises after 4 hours, peaks at 24 hours, that is 1 day, and is increased for 7 to 10 days. And it is more specific. Next is CKMB. CKMB rises late and also depletes early. So for short period, rises after 6 to 12, peaks at 1 day, and predominantly in myocardium, normal in 2 days. It is important for reinfarction because it disappears in 2 days. If it persists after 2 days, it is a reinfarction. Management of acute STEMI, SONUBs. S. Supplemental oxygen if SaO2 is less than 90 or dyspnea. N. Nitrate sublingual. A. Aspirin 325 mg highest dose. Antiplatelet P2Y12 inhibitor, that is clopidogrel. And now these rest 3 drugs depends on the situation. First is anticoagulant, depends on the planned revascularization. Beta blocker is given but is contraindicated if decreased BP, that is hypertension, decreased heart rate, that is bradycardia, and if cardiac heart failure or heart block or pulmonary edema is present. Statins high dose, example 80 mg atorvastatin, example it's given. Now, if first scenario, if the patient has persistent pain, hypertension or heart failure, then we have to give something to control the hypertension and pain. So intravenous nitroglycerine is given. It is not given if the patient is obviously in hypotension or if there is a right ventricular infarct or severe aortic stenosis occurs. Because right ventricular infarct तो फिर हमारा जो है पंप नहीं कर पाएगा और hypertension और करवा देगा, and severe aortic stenosis cannot send out और ऊपर से हम venodilation करवा देंगे, तो इसलिए नहीं. Persistent severe pain, intravenous morphine is given. Intravenous morphine is anxiolytic and decreased preload, not used routinely. Unstable sinus bradycardia, we give intravenous atropine. And pulmonary edema can occur after ischemic heart failure secondary to MI. We call it flash pulmonary edema. We have to give diuretic intravenous furosemide, not if patient is hypertensive or hypovolumic. After all this, we do reperfusion. Reperfusion, we give PCTA, that is percutaneous transluminal coronary angioplasty. Within 90 minutes is preferred. Thrombolysis if PTCA not available within 120 minutes. Inotropic agent, example dopamine, dobutamine, may be needed for RVMI patients with persistent hypertension despite adequate fluid resuscitation, and we cannot give nitroglycerine in RVMI patients. If MI occurs in a patient with recent stent, most common cause is medical non-compliance, and the cause is stent thrombosis. Stent thrombosis is a potentially fatal complication of coronary artery stenting, and long-term dual antiplatelet therapy with aspirin and platelet P2Y12 receptor blocker is recommended to reduce this complication. Premature discontinuation of these meds is the strongest predictor of stent thrombosis within the first 12 months. Screening and counseling regarding medicine compliance is needed. Aspirin is in full dose to be chewed for quick action. Morphine can also be given for pain control if nitroglycerine is insufficient. Nitroglycerine mainly causes dilation of the coronary vessels, veins, also dilate arteries, that is decrease after load, but this is not significant. Current guidelines for PCI for patients with acute STEMI are within 12 hours of symptom onset, within 90 minutes from first medical contact to device time at PCI capable facility, within 120 minutes from first medical contact to device time at non-PCI capable facility to allow time for transport to a PCI capable facility. PCI has better survival and less risk of MI and stroke as compared to fibrinolytic therapy, which can be done if within 12 hours of symptom onset who cannot undergo PCI. PCI is not available within the recommended time frame. If fibrinolytics are being used, then door to needle time should be ideally 30 minutes. Management of NSTEMI revascularization with drug-eluting stent is done, and long-term therapy for secondary prevention. All these drugs are given after discharge of the MI patient. First is dual antiplatelet therapy, aspirin plus P2Y12 receptor blocker, clopidogrel, prasugrel, ticagrelor. It leads to significant reduction in recurrent MI and CVS death compared to aspirin alone. Long-term DAPT reduces stent thrombosis, recommended for at least 12 months in all patients following drug-eluting stent. Beta blockers, ACE inhibitors, ARBs, statins, and aldosterone antagonists are given only if ejection fraction is less than equal to 40% with heart failure symptoms or DM. ACE inhibitors should be started in all patients with MI within 24 hours to prevent remodeling of the heart, that is, dilation of the left ventricle with thinning of the ventricular wall, which takes weeks to months. Now, apixaban. Apixaban is a factor Xa inhibitor. It is not used in this case. It is used for anticoagulation in non-valvular atrial fibrillation management and also management of DVT and pulmonary embolism. That is, it is an anticoagulant, not antiplatelet.